everyone. I thank Dr. Chandrasekhar sir, AIOS Scientific Committee for giving me this opportunity. My presentation will be on optic atrophy. Optic atrophy is not a disease in itself but a clinical sign characterized by pallor of optic disc caused by irreversible damage to the retinal ganglion cells and axons. It is the end stage of a disease process affecting the retinogeniculate portion of the visual pathway. There will be change in color and structure of the optic disc associated with variable degrees of visual dysfunction. There are 1.2 million axons of ganglion cells of retina which are heavily myelinated by oligodendrocytes, and they remain unmyelinated until traversing lamina cribrosa. Axons are optically similar to a fiber optic cable, and the incident light undergoes total internal reflection in the axonal fibers, and the light reflected back by the capillaries on the disc surface gives a yellow-pink color to the normal healthy disc. And the degenerated axons don't possess this optical property, giving a pale appearance of the atrophic disc. Ophthalmoscopically, we classify optic atrophy into primary, secondary, consecutive, and glaucomatous optic atrophy. In primary optic atrophy, there will be orderly degeneration of the optic nerve fibers, which are replaced by columns of glial cells, no previous swelling of the optic disc, no alteration in the architecture of the optic nerve head, and the disc is chalky white in color, sharply demarcated, and the retinal vessels are normal. Lamina cribrosa is well seen. The common causes are pituitary tumor, tumor of the optic nerve, traumatic optic neuropathy, and multiple sclerosis. Secondary optic atrophy occurs as a consequence of long-standing swelling of the optic disc. There is marked degeneration of the optic nerve fibers and excessive proliferation of glial tissue, and the architecture is lost, resulting in an indistinct margin. There will be dirty gray color of the optic disc with margins poorly defined. Lamina cribrosa is obscured by proliferating fibroglial tissue, and there will be peripapillary sclerosed vessels. The most common causes are papillitis, anterior ischemic optic neuropathy, and papilledema. In consecutive optic atrophy, there will be waxy pallor of the disc with a normal margin and physiological cup with marked attenuation of arteries. The causes are retinitis pigmentosa, status post central retinal artery occlusion, or other retinal and choroidal pathologies. In glaucomatous optic atrophy, there will be marked cup with vertical enlargement, laminar dot sign, backward bowing of lamina cribrosa, bayoneting and nasal shifting of retinal vessels with peripapillary halo and atrophy. This slide shows the etiological classification of optic atrophy. They can also present as temporal pallor of optic disc. The temporal side of the disc is normally paler than the nasal side because there are more fibers nasally. So a real temporal pallor is pallor of the disc associated with the signs of optic nerve dysfunction. The causes can be chiasmal compression, toxic or nutritional optic neuropathy, and cone dystrophy. There are other non-pathological causes for temporal pallor which has to be differentiated from, like axial myopia, myelinated nerve fibers, optic disc pit, tilted disc, optic nerve hypoplasia, disc coloboma, and optic disc drusen. So the aim of clinical evaluation in a case of optic atrophy is to determine the possible cause of the disc pallor, whether there is an ongoing process which is likely to progress as in compressive etiology, or is it a result of a previous one-time insult like ischemic, traumatic or toxic etiology which is going to be static, and to determine the visual prognosis. In all these cases, the prognosis will be guarded, and here our main aim will be to preserve the functional vision whatever is remaining, and also to protect the fellow eye and to decide on the further intervention. Detailed history is very important in cases of optic atrophy, including defective vision, whether it is sudden or gradual, painful or painless, progressive or static, any history of trauma, obstructive sleep apnea, and medication history including diabetes, hypertension, hyperlipidemia, cardiac issues, stroke, and mainly anti-tuberculosis treatment including ethambutol, history of smoking, alcohol or tobacco intake. And a review of records is very important in all cases of optic atrophy because we are seeing the patient at some time later where the pathology has occurred previously. The examination should include best corrected visual acuity, color vision, visual fields, contrast sensitivity, and pupils will show RAPD in unilateral and asymmetric cases, and fundus examination. Here I am presenting a case of 49-year-old female who came with complaints of defective vision in both eyes for past 2 years, which was gradually progressive, no history of trauma, and the best corrected visual acuity was 6.9 in right eye and 6.6 parts in left eye, with ill-sustained pupil reaction and impaired color vision in both eyes. This was her fundus picture, which showed both eyes primary optic atrophy, and her visual fields showed bitemporal hemianopia. An MRI was done, which showed a pituitary macroadenoma. And 3 months post excision of the tumor, this was a visual field which showed resolution of field effect in the left eye, but still there is persistent defect in the right eye. So in cases of chiasmal compression, we need not get classical bitemporal hemianopia in all cases. Sometimes it can be asymmetric. They can have poor vision in one eye and the other eye showing temporal hemianopia, or depressed field in one eye and supratemporal hemianopia in the other eye, junctional scotoma. So if the affected eye is having very less vision, always HFA of the fellow eye has to be done, which will give us the clue. So all cases of primary optic atrophy warrants neuroimaging to rule out chiasmal compression or space occupying lesion. And it can occur post retrobulbar neuritis also. So history and review of records is very important in such cases, and we have to see whether they are adequately evaluated, including NMO and MOG antibody, to prevent further recurrence. Another patient, 56-year-old male who was diabetic, hypertensive and hyperlipidemic with complaints of defective vision in right eye for past 1 year, which was sudden in onset and painless, and defective vision in left eye, which was for 4 months, which is again sudden onset and painless. Had a best corrected visual acuity of 5/16 in right eye and 6/12 in left eye, and he was not able to read the color plates in right eye, and the left eye was normal. He had ill-sustained pupil reaction in both eyes. This was his fundus picture, which showed secondary optic atrophy in right eye and a sectoral pallor in the left eye. And Humphrey visual field analysis of the left eye showed inferior altitudinal field effect. So we came to the conclusion of diagnosis of secondary optic atrophy, secondary to non-arthritic anterior ischemic optic neuropathy. So as this was covered by Dr. Saravanan sir, NAION will present with altitudinal field effect, and the other eye will have a disc at risk, and blood investigations has to be titrated to look into the systemic parameters, and cardiac evaluation and Doppler study has to be done to rule out thromboembolic causes, and CRP and serum homocysteine has to be done in these patients. And long-standing papilledema can result in secondary optic atrophy. So they will be bilateral. They will be having history of headache, vomiting, transient obscuration of vision, and tinnitus. Once a secondary optic atrophy has set in, this disc will not show any edema again when there is increased intracranial pressure. A dead nerve cannot swell again. So in such cases, B scan to look for crescent sign will be more helpful. In toxic optic neuropathy, after the change in the regimen of anti-tuberculosis treatment, we are frequently seeing ethambutol optic neuropathy, and the mean duration for the toxicity to develop is 8 weeks, and they present with bitemporal field effects. So timely cessation and replacement of ethambutol will save the vision. If there is no improvement or worsening of the vision even after stopping ethambutol, then neuroimaging has to be done to rule out other causes, and also we have to consider INH toxicity. Linezolid is another drug which is used as a second line treatment in tuberculosis treatment, that is also noted to have optic neuropathy. And in all cases of tobacco alcohol induced optic neuropathy, neuroimaging once has to be done to rule out central causes before labeling it as tobacco alcohol amblyopia. A nutritional optic neuropathy, usually these patients present to us with a headache, and the vision will be good, and they can present as a diffuse pallor or a temporal pallor of the optic disc. For all these patients, along with anemia treatment, Humphrey visual field analysis has to be done once, not to miss any coexistent central cause. Traumatic optic neuropathy can present as primary optic atrophy. It takes 1 month for the atrophy to set in from the time of trauma. review of records and history is very important in all these patients. If the history is not accounting for traumatic optic neuropathy, neuroimaging is needed. And we have to see whether adequate neuroimaging has been done, indirect ophthalmoscopy to look into the retinal peripheries, and Humphrey visual field analysis of the fellow eye has to be done, and these patients has to be given protective glasses. Lastly, compressive optic neuropathy can present as a gradual painless loss of vision with a relative afferent pupillary defect. They can have any field defect and transient obscuration of vision on eye movements. It can be caused by chiasmal compression due to pituitary macroadenoma, craniopharyngioma or suprasellar meningioma, or optic nerve tumors like glioma, meningioma, and thyroid eye disease or orbital tumors. So to conclude, optic atrophy is not a disease in itself, but a clinical sign. Thank you.
Thank you, Karthik. Really nice explanation of all this